Thank you. Are you okay to do my slides, Sandra? Yeah.
Yeah.
Hi, I'm one of the Pams. You've got two presenting today, always a bit confusing. I'm a practice nurse. I work in a GP surgery in Southampton, and we have a practice population of about 9,500, and we have 256 on our cancer register as of this morning. My role in that team is cancer care nurse. And it's my responsibility to provide personalised care to people from their point of diagnosis throughout their treatment and beyond, and to help them navigate living with cancer and supporting them through the late effects of treatment. I often do bereavement care for families also, for some people. That personalised care includes a clinical lead, which is myself on both the 3 and the 12-month cancer care reviews, which follows on from Julie very well. I do work with social prescribers and a care coordinator, but we do keep the lead for the reviews with a clinician. That's the way that we found it fits in best with our surgery. As part of that role, I am also involved in the Right by You project, which is a Wessex Cancer Alliance project that offers care from cancer specialists in patients' own home for themselves and for their families. And within that project, I have a lead sort of learning and development role to provide mentorship to other practice nurses that are wanting to be involved in cancer care in their surgeries, whether that's the same as the way that I work or whether it is doing the reviews and then not keeping an active caseload afterwards. First slide, Sandra, please. So we approached mentorship several ways, and we're a few years on now, and we found that this was the way that worked the best with us. So we use the RAID type of cycle. So we offer a review in that practice to what their current practice is, and whether there's opportunities to work differently, whether we're missing contacts that potentially could then promote a cancer care review. An example of that is people for attending for Zoladex injections with the practice nurse, and looking at how that appointment could then actually be utilised for a cancer care review at the same time. We do a training needs assessment at the beginning, and then from that sort of develop a bespoke support system. I think there's a few of my mentees on the line today, and some of those choose to do Teams meetings, but mostly it's face-to-face. And I go into their practices and they will also come into mine to see how I work. We've developed a portfolio of learning to support them during that process. And that's a very collaborative, self-directed portfolio that we will actually be revisiting to try and actually incorporate some support for ARS roles within that portfolio as well, and also AHPs. And then we go back, revisit where we started to see what's changed, what impact has been made, and to assess how personalised care is now at the forethought of cancer care reviews, as opposed to a tick box exercise. Next slide, Sandra, please. The portfolio is a huge document to do electronically, so it wasn't possible to download. We did try. So we've just done the contents page on there. We have got in there learning exercises that link to the site and actually offer a time of what you're expected to take to do that learning exercise, so people can see whether it fits in at a time of the day that they would be able to do it. There's 6 in there at the moment on the learning exercises, but we're looking to sort of develop and expand that now that this was our draft, really. We've sort of used this with some of the mentorship that I've been doing, and we do need to develop it further. We've linked in a learning log, so there's reflection in there as well for people to be able to use, and also a link and an NMC revalidation page as well, so it will help with their appraisal and their revalidation. Next slide, Sandra, please. We've also developed a community of practice that we meet alternate months, and that's always via Teams at the moment. We use that as a safe platform for people to come and talk about case studies. And we have guest presenters from secondary care and the voluntary sector, and it's a very mixed audience, which has proved to be really positive. So we've got secondary care, primary care, we've got voluntary sector, we've got hospice nurses, community nurses, and we all join at that meeting and share our learning experience and support each other as well. We are looking to change the terms of reference on that and to sort of upscale to other localities, and also to collaborate with the Ours Roles Cancer Care Coordinators. So that's in process at the moment. And in a nutshell, that is our mentorship offer from the Right By You Wessex Cancer Alliance.
Thank you, Pam. I think hopefully we have Pam Campbell on the line as well. I was going to talk very briefly about Right By You in Wessex. Pam, you're very welcome to come back at a later date for a whole slot if you want one. So, Pam, are you out there?
I am out
like
here.
it.
Yeah, because that is my one and only slide. So I am not going to. I'd love to be that Pam that got that all that accolade at that one. But I'm the other Pam in Southampton. So we both work for Right By You, which is personalised care for people. And as Pam's talk described, personalised care throughout the journey, diagnosis, treatment, post-treatment, bereavement, and that's crucial. My end of the journey, and I'm not a cancer specialist nurse, is around supporting people who are experiencing homelessness or on the move. So anybody can be referred, whatever their precariosity of housing is, or somebody who is seeking asylum, migrating, no recourse to public funds, and more recently, people from the Homes for Ukraine. So Right By You is the crux of the matter, and personalisation is our job. And I just need to think about people who really have no home to go to. So I think the easiest way to describe some of the work is to quickly tell you two stories, but I thought I'd start by talking about the support I get from my colleagues who are much more au fait with the world of cancer. And that's both Pam in primary care, and I'm going to pinch one of her sayings, which was from one of her patients, which talked about being cared for by two fantastic teams, of course, of which one was Pam. But how neither team talked to each other. So she had the acute trust and she had the community. So whatever was happening in the hospital was fantastic, and it was really well coordinated. She was also supported in the community. You can listen to Pam and how the reviews went on, but neither talked to each other. So, my experience would echo that people are sitting on hospital wards, and often the ward doesn't know that they've got nowhere secure to go home to. And it may be that they did have, but they don't have any longer, or they simply didn't have, and there's an old historical address on their record. And such is the nature of acute care that we've been lobbying for years for that question about security of accommodation to be asked at admission, not the day before discharge or when treatment's beginning. So I came to this job because somebody, very astutely from my point of view, I'd retired after 30 years of working as the clinical lead for the homeless healthcare team in Southampton, which is a primary care provision. So somebody said, "Oh, what Right By You now needs is somebody that works and understands a little bit about homelessness benefits, rights to healthcare, habitual residency, recourse to public funds." And I'm sure every single one of you has been bitten by one of those terms and the impact it's had on your patients. So the very first patient I picked up in October 1902, no, 2021, coming up for 2 years ago, was Hannah. And I'd known Hannah in my primary care guys for probably 15 years, and we chipped away at her having her cytology uh, tests performed, but never actually got there. And a lot of that was associated with the fear and the trauma that she'd experienced as a young woman. When I met her, she'd been admitted to UHS, our local hospital, from her home on the streets, living under a railway bridge in the town centre, and she was diagnosed with terminal cancer of the cervix, and we had to look at her wishes. So personalising the care meant having a really good listening to about what she wanted in terms of the end of her life. And, pivotal to those were continuing to use substances. It's a really contentious issue. Her consultant oncologist thought that with a terminal diagnosis, she'd probably stop using heroin now. I found that a really interesting response. However, understanding it from Hannah's point of view was really, really much more important to me. She decided that she would like to end her life in a local hostel, which some people wouldn't describe as a home, but for her, it was one of the only homes she'd known over her 20 years of homelessness. So we negotiated with them. And hostels generally are a little bit risk averse about taking people in who are coming in to die, despite the fact that people die in hostels lots and lots. But it's often associated with bad press. And we'd like to turn that on its head and say, actually, if somebody chooses to die there because it's the place they feel most comfortable in, then that's a good thing. And it's far better than dying on the streets where we couldn't even arrange, a morphine pump that wasn't going to be connected to somebody else. So it was kind of crucial. But isn't it amazing the way the third sector, and I loved that's what's gone through Julie's and Pam's talk, is the collaboration that occurs. But isn't it lovely that you can work with the third sector and they're pretty much, we can do this. You may have to bring along some staff, but that's often a question of giving them good mentorship and opening up your listening skills to their concerns. But they agreed to take Hannah in, and we together negotiated many obstacles to her care, like, as I said, getting regular pain relief to her, ensuring she wasn't being exploited, but that we could also make her safe in the times when she did choose to use illicit drugs. And mentoring some of those staff for whom it evoked many of their own concerns, grief, and bereavement experiences, and their fear that they might be the one that opened her room door and found her dead. So, I think that was key to my work with her. Also working with the oncologists, and attending with her and beginning to understand mutually their perception of Hannah's wishes towards the end of her life. There was such a passage of her through a journey that I learned enormous amounts. But at the end, a month before she died, she felt brave enough to make a television appearance, urging people in her position to go and get their smears, their cytology done, because of what had happened to her. And that was the most amazing denouement to her story, to be able to be there when she appeared on Meridian, and then for the days, the days that followed, for her to get messages from women who had booked their smear test on the basis that she had overcome her own struggles to tell them of her own story, and how a difference could be made by early detection. And I think one of the things I want to talk about really, within the cohort of people, and I'm aware time is pressing, that we pick up, is that so many of the diagnoses are late. And we don't get to the point of the cancer care reviews because, like Hannah, who died in May last year, just over 6 months after her diagnosis, it was late, and a trajectory towards a positive outcome of her treatment was highly unlikely from the outset. The other one I want to talk about, I mean, is a bit more about people who don't choose to live and die in a hostel in the end of their life. And Mikey was a 43-year-old man diagnosed with a primary of unknown origin, but metastases throughout his body. And at 43, he knew of the hostels and had been homeless with his father, whom he nursed through esophageal cancer, and did not want to die in a hostel. He wanted some private accommodation. And I'm sure that in every city up and down this range of participants in our current meeting, housing is of an absolute premium. In Southampton, we moved to a point probably 15 years ago where we were no longer using bed and breakfast, either for families or for single homeless people. That's changed. It changed with COVID, which was perhaps a good reason, everybody in, but we now have 80 families living in bed and breakfast. And the first suggestion of housing. Can you hear me?
Yeah, you muted yourself. I don't quite know how.
I don't know how I did that.
But just to say, you've probably got about 60 seconds to wrap up. I'm sorry.
Yeah, okay, that's fine. And I will just simply say that the necessity to advocate and urge housing to look at cases like that, where he spent 5 of the 7 months he had left of his life sitting on a hospital bed, and people using that pejorative term bed blocker, where he neither wanted to be there and nor the staff, was quite traumatizing for all of us, but we eventually did find him some accommodation. I think that brings me to the end of my 60 seconds. Thank you very much.